let us now move forward and discuss regarding the laboratory evaluation and subsequent management of a case of mitral regurgitation. So first of all, beginning with the laboratory evaluation, the lab evaluation. So first of all, let's see what are the expected ECG findings. In a patient with mitral regurgitation, yes, obviously you are going to get features of LA enlargement. And as we have discussed in the ECG module, whenever you get an LA enlargement, you are going to have a broad P wave with a duration more than 120 milliseconds and best appreciated in the lead V1 and with notching also, and this is what is called a P mitral. You can get the same finding in case of mitral stenosis as well. And even in lead V1, you are going to appreciate a significant negative component. Okay. So will you get features of RA enlargement? Tell me, what about RA enlargement? Are you expecting RA enlargement in this patient? Well, it's a plus or minus. Okay. It's a plus or minus. The reason is because in case the patient is having significant pulmonary hypertension, in that case, RA enlargement may be present. Okay. So it may or may not be present. And what about the ventricles? Are you expecting any sort of ventricular hypertrophy? Yes, you may get eccentric LV hypertrophy. You may get eccentric LV hypertrophy. So that is also a plus minus. Well, that depends on the chronicity and the severity of mitral regurgitation. And also, please note that patients with mitral regurgitation, especially chronic severe mitral regurgitation, is frequently associated with atrial fibrillation. So you may or may not have atrial fibrillation as well. Okay, may or may not have atrial fibrillation. So these are the important ECG findings. And let's move forward and discuss what are the echocardiogram abnormalities. Okay, echocardiogram abnormalities in patients with mitral regurgitation. So definitely echo is recommended in patients who are either known or suspected to have mitral regurgitation. And how is this going to help you? It is definitely going to give you an idea regarding the severity of MR, what is the etiology for MR, and a very good idea on the hemodynamic consequences of the mitral regurgitation. Okay, so you are going to get an idea of the assessment of the LV function as well from the LV end diastolic and LV end systolic volumes and also the ejection fraction. Moreover, you are going to get idea regarding the finer structural details like the leaflet structure and function. What about the integrity of the chordae? What about the LA-LV size? Is there any annular calcification? And also an idea regarding the regional and global LV systolic function. Now, when you do the echo in patients with mitral regurgitation, the LA size, the left atrial size, you are definitely expecting an increase in the LA size, correct? You are expecting an increase in the LA size. The left ventricular size and the systolic function, well, they are quite normal early in the disease course. But as the disease progresses and you get a progressive ventricular dilatation, there is a decline in the ejection fraction that occurs with a chronic severe mitral regurgitation. Okay, so LA size increases and LV size and the systolic function depends on the stage of the mitral regurgitation. Okay, so let me also tell you that see, when you compare the transthoracic echocardiography and transesophageal echocardiography, Well, the transesophageal echocardiography definitely provides greater anatomical details than a transthoracic echocardiography. So, in practice, when the transthoracic echocardiography is providing an insufficient information or a discordant information, then you will rely on the transesophageal echo for the evaluation of the severity of MR, what is the mechanism of MR, and the status of the LV function. And definitely you can go for a Doppler echocardiography. Okay, you can go for a Doppler echocardiography. So Doppler echocardiography gives you the additional utility of Doppler imaging. And how is this going to help you? Well, this will actually demonstrate the width or the area of the regurgitant jet flow. So one point is that this will give a fair idea on the width or area of the color flow jet of regurgitation. That is number one. And number two, it gives you an idea regarding the regurgitant volume. Okay, it gives you an idea regarding the regurgitant volume. Okay. The next point, it gives you an idea regarding the regurgitant fraction. It gives you an idea regarding the regurgitant fraction. Okay. And finally, it gives you an idea regarding the ERO or the effective regurgitant orifice area. Effective regurgitant orifice area, which is the ERO, effective regurgitant orifice area. So these are the points that you should keep in mind. And another point that you should know is about the echocardiographic criteria for a severe MR. So based on echocardiography, what is a severe MR? Okay, severe MR on echocardiography. So one is when the regurgitant fraction is more than or equal to 50%. Point number one, regurgitant fraction more than or equal to 50%. The second point, when you get the effective regurgitant orifice area, which is more than or equal to 0.4 centimeter square. Okay. So when the effective regurgitant orifice area is more than or equal to 0.4 centimeter square and the regurgitant volume is more than or equal to 60 ml. Okay. The regurgitant volume more than or equal to 60 ml. So this is when you say this is a severe MR. So we have seen regarding the ECG findings. We have seen regarding the echocardiography findings. Third one about the chest X-ray. Chest X-ray. Well, chest X-ray, what is the most common finding that in chest X-ray you are going to expect? Definitely is the cardiomegaly. Okay, is the cardiomegaly. Okay, cardiomegaly. So cardiomegaly commonly results from the enlargement of the LV and the LA. Okay, it's commonly a sequelae of the LV and LA enlargement. And when you get a left ventricular enlargement, this will cause the cardiac chamber to be of a globular shape. Okay, so you will have the cardiac chamber assuming a globular shape. And see, I told you there is LV and LA enlargement. So what implication does a LA enlargement have on a chest X-ray? See, when you have a LA enlargement, you're going to find there is a straightening of the left heart border. Okay, there is a straightening of left heart border. Point number one. Point number two, Well, you have the double density sign, the appearance of the double density sign. I'll come to it. What is this double density sign? And then you can have the elevation of the left main stem bronchus, elevation of left main stem bronchus. Okay, so these features are important. See, what I want you to understand is the right heart border is formed by the right atrium. The inferior border is formed by the right ventricle. The left border is predominantly by the left ventricle. So right heart border, right atrium, inferior border, right ventricle, the left heart border by the left ventricle. The left atrium is located posteriorly, and only the left atrial appendage is visible on a normal frontal projection. So what happens is, I want you to have a look at this particular X-ray. When you have the inlay that becomes enlarged, you can have this atrial enlargement which is visible as an extra heart shadow parallel to the right heart border. Okay, parallel to the right heart border, you are seeing this extra heart shadow, and this is what you call this double density sign, okay, or the double right heart border. Okay, and I also want you to compare and contrast these two X-rays. The first one being a normal X-ray and the second one being of a patient with a mitral regurgitation. So you can see that you are having features of both say LA enlargement and also LV enlargement. Okay, so these points are important to note in patients with mitral regurgitation. And also understand, in addition to these points, you may also have patients with calcification of mitral leaflets. Okay, calcification of mitral leaflets. So the calcification of the mitral annulus, it is best appreciated in the lateral view of the chest. And this commonly happens in patients with long-standing, often a combined rheumatic MR and MS, where you might get this calcification. So that also may be seen, that is the chest X-ray findings. Okay. And yes, you may also have other X-ray findings of say a pulmonary edema as and when the patient develops the manifestation. Then about CMR, that is the cardiovascular magnetic resonance. So routinely the cardiovascular MRI is not recommended for the diagnosis of mitral regurgitation. But in situations where the echocardiographic findings and the symptoms are discordant, you may have utility of the cardiac MRI. And what about the role of the invasive cardiac catheterization? What about the role of the invasive cardiac catheterization? Well, invasive cardiac catheterization for the measurement of intracardiac pressures, they're not routinely recommended for the evaluation of a chronic mitral regurgitation. But once again, if the non-invasive tests are inconclusive or there is some sort of a discordancy or a discrepancy between the symptoms and the non-invasive testing, that is when you might go for a cardiac catheterization, and you will get a fair idea of the severity of mitral regurgitation, the LV function, and also the need for surgery. So this is how you will evaluate a case of suspected mitral regurgitation. Okay. Now with that in mind, let's move forward and discuss regarding the management of mitral regurgitation. So the management points that I'm going to discuss with you are from the 2020 ACC/AHA guidelines for the management of patients with valvular heart disease. So what I want you to understand is, as far as the management goes, okay, as far as the management of mitral regurgitation goes, well, it actually depends. Depends on what? It depends on whether it is a case of a chronic mitral regurgitation or it is a case of a acute mitral regurgitation. Chronic mitral regurgitation or acute mitral regurgitation. And in case of chronic mitral regurgitation, well, it again depends on whether this is a primary MR or it is a secondary mitral regurgitation. Okay, secondary mitral regurgitation. So let's first discuss about the management of chronic primary MR. And from the management point of view, there are certain stages, okay, stages of chronic primary MR. Chronic primary MR, the stages. Okay, so let me tell you that it is basically divided into 4 stages. Okay, you have got stage A, stage B, stage C and stage D. These are the 4 stages. Stage A means patients at risk of mitral regurgitation. Patients at risk of mitral regurgitation is the stage A. The progressive mitral regurgitation falls under the stage B. Okay. Stage C is asymptomatic severe MR. Asymptomatic severe mitral regurgitation. And finally, symptomatic severe MR is stage D. Symptomatic severe mitral regurgitation is stage D. So this is about the staging of the chronic primary MR. And if you see this table from Braunwald, in fact, this is the latest guidelines as well on how you would classify the stages, stage A, B, C and D. So this staging is based on parameters like valve anatomy, what are the valve hemodynamics, the hemodynamic consequences and also the symptoms. So valve anatomy, hemodynamics, hemodynamic consequences and symptoms. It is based on this that the staging is done. So when I say valve anatomy, I mean how severe is a mitral valve prolapse, what is the extent of rheumatic valve changes, was there any prior infective endocarditis, is there any valve leaflet thickening, all these factors. And regarding valve hemodynamics, what is the regurgitant volume, what is the regurgitant fraction, what is the effective regurgitant orifice, what is the regurgitant jet area, these parameters. About the hemodynamic consequences, the LA size, the LV size and function, the pulmonary artery pressures, all these are important. And obviously the symptoms. Now, see, when it comes to the staging A, B, C and D, please understand that the C staging will have C1 and C2 components. Okay. So the stage C, which is the stage of asymptomatic severe MR, it is having again 2 components. One is stage C1 and the other is stage C2. So what is the basis of such a staging? This is based on the left ventricular ejection fraction and the LVESD, which is the left ventricular end systolic dimension. So in case of stage C1, the left ventricular ejection fraction or the LVEF, this often is more than or equal to 60%. Okay. In fact, the criteria says more than 60%. Okay. Left ventricular ejection fraction more than 60% and the left ventricular end systolic dimension less than 40 millimeter. Okay. Left ventricular end systolic dimension less than 40 millimeter. Whereas when it comes to stage 2, you will have a left ventricular ejection fraction less than or equal to 60% and left ventricular end systolic dimension more than or equal to 40 millimeter. This is how you will divide or subdivide. So remember, in all patients with a known or a suspected primary mitral regurgitation, you're definitely going to go for a transthoracic echo, and you have to have a baseline evaluation of the LV size and function, the RV function, the LA size, the pulmonary artery pressure, and what is the mechanism that has led on to the primary mitral regurgitation. And as I told you earlier, when the transthoracic echocardiography is providing an insufficient or a discordant information, you will go for a transesophageal echocardiography to understand the severity of MR, mechanism of MR, and the status of the LV function. And when again there is a discrepancy between clinical assessment and echocardiography, you might even go for the cardiac MRI, where you will get an idea regarding the LV, RV volumes and function, and also the severity of MR. Okay. Now let's try to see more about the management. And before that, let me also tell you the role of intraoperative transesophageal echocardiography. The role of intraoperative transesophageal echocardiography. So intraoperative, see, in patients with a severe primary mitral regurgitation, and suppose they are undergoing a mitral intervention, in that case you can go for an intraoperative TE. This will help you establish what is the anatomical basis for the primary MR. Okay, this will help you to establish what is the anatomic basis for the primary mitral regurgitation, and this will also help to guide repair. Okay, this will also help to guide repair. This is the utility of the intraoperative transesophageal echocardiography. And if you have a patient and you are having the patient in follow-up, see, when you have a patient with a primary MR and the stages B to D, whenever they develop new onset symptoms or changing symptoms, definitely you will have to repeat your transthoracic echocardiography so as to evaluate the mitral valve apparatus and to have an idea regarding the left ventricular function. Okay, so that point is also important. And coming to the management, yes, you will have medical management and surgical. So first, what about the medical therapy? Okay, what about medical therapy in patients with chronic primary MR? So let me tell you, medical therapy has a very limited role. Okay, very limited role in chronic primary mitral regurgitation. Why? Because none of the medications are going to alter the primary disease process. Then in what scenarios does it have a role? Well, let's imagine a patient who is having a severe mitral regurgitation and a LV systolic dysfunction, and for some reason the surgery is not possible, or maybe the surgery is delayed. In such a case, you will have to have a symptomatic management of the LV dysfunction, and yes, in this scenario, medical management has a role. And what about the role of infective endocarditis prophylaxis, i.e. prophylaxis for medical management? Well, i.e. prophylaxis, generally, let me tell you, antibiotic prophylaxis is not recommended when you have patients with mitral valve disease who are going to undergo a dental or other invasive procedures. So the point I want you to understand is the antibiotic prophylaxis is not recommended, but you will have certain exceptions. Okay, so it's important to know what are the exceptions. So the exceptions are in case of a prosthetic valve replacement or a previous history of an infective endocarditis. So if there is a history of a prosthetic valve replacement or a prior history of infective endocarditis, then yes, these are exceptions. And what about the role of secondary prevention of rheumatic fever? Okay, secondary prevention of rheumatic fever. Well, see, definitely yes. In patients with rheumatic heart disease, long-term prophylaxis against rheumatic fever is important. So there is no doubt regarding that. So this is a yes. Okay. So that's in short about medical therapy. And let's move ahead with the surgical intervention. Let's move ahead with the surgical intervention. So regarding surgical intervention, well, when to proceed with surgical intervention is the first thing that you have got to know. See, we all know mitral regurgitation as a slowly progressive valvular heart disease. So the decision has to be based on a risk versus benefit analysis, because obviously the surgical mortality is going to depend on the patient's clinical and hemodynamic status, especially the left ventricular function, the age of the patient, whether he has any comorbid illness, any cardiac, renal, hepatic or pulmonary disease, the skill and experience of the surgical team. So it depends on a multitude of factors. So it has to be a thought out decision. But let me ask you another question within this. Which will you go for if at all you're going for a surgery? Is it ideally going to be a valve repair or is it going to be a valve replacement? So repair or replacement is always a question. Please remember, the risks are lower with a valve repair, that is using the various valvuloplasty techniques, than for valve replacement. So whenever possible, you have to go for a valve repair over a replacement. And if at all you're going for a replacement, there are two choices for the surgical heart valve replacement. And one is a mechanical valve. There is an option of a mechanical valve and also the option of a bioprosthetic valve. Mechanical valve and a bioprosthetic valve. And yes, you will have adverse consequences of valve replacement. So you can have adverse consequences. So whenever you use a mechanical valve, there are chances of thromboembolic and hemorrhagic events. Thromboembolic and hemorrhagic events. Whereas in case of bioprosthetic valve, there are chances of, one is the late valve failure. Late valve failure. And this often requires a repeat valve replacement. Now, another point that actually favors a valve repair over a replacement is that, see, in case of repair, the integrity of the papillary muscles, the subvalvular apparatus and the chordae tendineae is preserved. So I can make a statement that the repair is more likely to maintain a proper left ventricular function. So that point is also important. And the management is pretty much dependent on the various stages. And if you see, this is a flowchart from Harrison on the, basically from the guideline itself, the latest guideline itself, on the management of patients with primary mitral regurgitation. So let me tell you, in case of stage D, so let's assume patients with stage D. So in case of stage D, as well as patients with stage C2, stage D and stage C2, definitely intervention is required. So stage D, the intervention is recommended irrespective of the LV systolic function. And even in case of the stage C2 also, the intervention is recommended. So the mitral valve surgery is recommended. And what about stages C1? What about the stage C1? And remember about the stage D and stage C2. If it is a degenerative mitral valve disease versus a rheumatic mitral valve disease, well, the difference is in terms of the class of recommendation. One is a class 1 and the other is a 2B recommendation. And coming to stage C1, well, see, in case of stage C1, you can definitely go for the surgery. And see, suppose if you have a scenario where the mitral valve repair is, or let's assume, say, it is a stage C1, and the patient is having a expected surgical mortality of less than 1%, with a more than 95% likelihood of successful and durable repair without residual MR. So basically what the guideline says is that in a stage C1, the mitral valve repair is reasonable when the likelihood of a successful and durable repair without a residual mitral regurgitation is more than 95% with an expected mortality rate less than 1% when it is performed at a primary or a comprehensive valve center. Okay, so that is one point that you should know. The second point is also in stage C1, when there is a progressive increase in the left ventricular size or a decrease in the ejection fraction on more than or equal to 3 serial imaging studies, then also the mitral valve surgery may be considered irrespective of the probability of a successful and durable repair. So once again, it's just about the class of recommendation. One is a 2A recommendation, the other is a 2B recommendation. Okay. So that point is also very clear. Now, another point that you should all note is that, when you have patients with severe symptomatic chronic primary mitral regurgitation and those with a high risk of a surgical mitral valve repair. Okay, so there are the patients with a high surgical risk, you can go for a minimally invasive procedure. And what do you call that minimally invasive procedure? It is called TEER, which is the transcatheter edge-to-edge repair. Okay, it is called the transcatheter edge-to-edge repair. Okay, transcatheter edge-to-edge repair. Okay, so that point also you should know. So I hope you are quite clear on the management of a chronic primary MR. Now next we are going to move forward and discuss regarding the management of chronic secondary MR. Okay, management of chronic secondary mitral regurgitation. So chronic secondary MR again is divided into various stages A, B, C and D, just like your primary MR. A is your at-risk MR or your at-risk mitral regurgitation. B is progressive MR. B is progressive MR. And C is asymptomatic severe MR. Asymptomatic severe MR. And D is symptomatic severe MR. Symptomatic severe mitral regurgitation. Okay, so basically as you can see from this table in Braunwald, so the staging of secondary mitral regurgitation is also based on, say, your valve anatomy, valve hemodynamics, but you see here the associated clinical findings are also taken into consideration. Okay, so that point you have got to know. And let's try to see more about this secondary MR. Yes, patients with a chronic secondary MR in the various stages from say B to D, you will have to rely on transthoracic echo to establish the etiology, to assess the extent of the regional and global LV remodeling that has occurred, about the degree of systolic dysfunction, severity of mitral regurgitation, and the magnitude of the pulmonary hypertension. So you may also have to rely on non-invasive imaging. At times, maybe the PET scan or a cardiac MRI or a stress echo or a coronary CT angiography. So all this will help you to establish the etiology of the secondary mitral regurgitation, and also obviously to assess the myocardial viability. Okay. And you have to rely on sometimes transesophageal echocardiography also, especially in the group of patients who are being considered for the transcatheter mitral valve interventions, because in such patients the transesophageal echocardiography will help you have an idea regarding the suitability for such a procedure. Okay, so in patients also with a chronic secondary MR who is undergoing transcatheter mitral valve intervention, always remember an intra-procedural guidance with a transesophageal echocardiography is definitely recommended. Now coming to the management, after having understood the stages, let's have a look at the medical therapy first. Okay, we have got the medical management and the surgical management. So medical management, well, chronic severe secondary MR, suppose with a reduced ejection fraction, you will have to rely on medical management for an aggressive treatment of heart failure. Okay, you might have to rely on this for an aggressive treatment of heart failure. That's forming the part of the medical management. So this might be in the form of this aggressive medical therapy, may be in the form of diuretics, beta blockers, AC inhibitors, maybe the angiotensin neprilysin inhibitors, or antagonism of the mineralocorticoid receptors, or SGLT2 inhibitors, or even, you can go for a pacing for a heart failure. So aggressive treatment of heart failure is very important. Second, what about the role of antibiotic prophylaxis? As I had stated before, well, antibiotic prophylaxis, even in secondary MR, it is not recommended in patients with mitral valve disease, and obviously I have already told you the exceptions, that is a prosthetic valve repair or replacement and a history of infective endocarditis. Only in those two scenarios you will think of antibiotic prophylaxis. So usually no, but with exceptions. Okay, usually no, but with exceptions. Okay, now what about intervention? And here again, this table is going to help you on secondary mitral regurgitation. So GDMT, that is the guideline directed medical therapy for heart failure, is very important. And let me tell you that if you have got a patient with chronic severe secondary MR and left ventricular ejection fraction less than 50%, okay, so suppose the patient is having a persistent symptoms of the grade of NYHA 2, 3 or 4, and in spite of the patient being on optimal guideline directed medical therapy, in such a case, if the mitral valve anatomy is favorable, that is in the form of a LV ejection fraction 20 to 50%, your left ventricular end systolic dimension less than or equal to 70 millimeter, and a pulmonary artery systolic pressure less than or equal to 70 millimeter mercury, in such a case you can go for transcatheter edge to edge mitral valve repair. So TEER is a possibility with a class of recommendation of 2A. Now in these patients you can also go for a mitral valve surgery, okay, with a recommendation of class of recommendation of 2B. And suppose if you have got patients with left ventricular ejection fraction that is more than or equal to 50%. So let's assume a patient who is having a chronic severe secondary mitral regurgitation that has occurred from atrial annular dilatation, and he's having a very much preserved LV systolic function, and he's having severe persistent symptoms like NYHA class 3 or 4. So despite all your medical management, the best medical management you have offered, So in such cases also, if the patient is having persistent symptoms on optimal guideline directed medical therapy and AF treatment, then with a class of recommendation 2B, you can go for surgery. And in patients with stage C and stage D, see, in patients who are undergoing CABG, when patient is anyway being treated for a CABG is already being undertaken for a treatment of myocardial ischemia, then again you can go for mitral valve surgery with a class of recommendation of 2A. Okay, so we have discussed in detail about the management of chronic primary MR and chronic secondary MR. Just a few points on management of acute mitral regurgitation. Well, acute mitral regurgitation, patients on an urgent basis will require symptomatic management and stabilization, which is of prime importance. Symptomatic management and stabilization. This is important. And then after that, you can proceed ahead with the surgical management. Okay, once you're done with the medical, you can go ahead with the surgical management. And diuretics you can give the patient. You can give the patient intravenous vasodilators, IV vasodilators. So diuretics, IV vasodilators like a sodium nitroprusside, which will help you for the afterload reduction, and maybe even a mechanical support in the form of intra-aortic balloon pump also might be useful in the management of acute mitral regurgitation. So this is about the lab evaluation and subsequent management of mitral regurgitation. So it's very important to discuss separately about the management of chronic primary MR, chronic secondary MR and acute mitral regurgitation. Okay.